Dr. Hassan is a pediatrician, and I'm going to let him introduce himself. He is also working with an organization called Boost Oregon that does some educational programs specifically around vaccines. So I'm going to turn it over to him, but before I do, if you have any questions, you can put them in the chat. Go ahead and put any of your questions as we go along in the chat. When we get to the end of the presentation, we will we'll get to your questions and we'll go and answer them as best we can. So Dr. Hassan, I'd like to turn it over to you.
Thanks very much. I appreciate that introduction. Before I start, I wanted to ask, I understand there was going to be some polling questions done first. Is that, have we done that?
Sure. These are just two quick questions, and I believe they're both going to display on the screen at the same time. The first is just kind of getting a general idea from our participants today about whether or not you are currently planning to receive the vaccine if it becomes available to you. And then the second is about whether or not you might what your concerns might be about some of the COVID vaccines. And all of these questions are anonymous, so we have no idea who is responding to which question in which way. So it looks like within our audience, 64% of people are planning to receive the vaccine when it's available. 34% of people are still deciding, and 3% have said no, they're not planning to receive the vaccine. And what concerns people might have, looks like about 23% of people said they don't want to be first. 27% feel it's too untested. The majority of people, 78% of people said that they are unsure of the long-term side effects, and 42% don't have the information they need to make a decision or to feel informed, and 9% said other reasons. So thank you very much for sharing that and helping us get a better idea about how our group today feels about these pending COVID-19 vaccines.
Thanks everyone for answering, and thank you both for that great introduction. So again, I'm Dr. Ryan Hassan. I'm a pediatrician. I work at Oregon Pediatrics in Clackamas. I've been working here for 3 years since I finished residency, and started partnering with Boost Oregon shortly after I moved here because of the awesome work that they do, which is primarily around educating patients and parents about vaccines. We mostly deal with childhood vaccinations, but we've started becoming kind of more involved with vaccination education in general. And we also do several talks similar to this, where we talk with other providers, healthcare providers, community workers about how to engage with families to just have knowledgeable discussions and information dissemination about vaccines. So I appreciate everyone answering those questions. Let me share my presentation here with you guys. I wanted to today talk a little bit about mostly the COVID-19 vaccinations and kind of an overview of what to expect with them. And I'm going to try to go through this fairly quickly to try and leave as much time as I can for questions, because I want this to be as much of a conversation as we can have on a Zoom platform. I think there's a lot of unknowns here. I don't pretend to be an expert on really vaccines in general, even though I talk about it often, but certainly not on COVID-19 vaccines. I've done as much research as I could on it. We've talked as an organization about some of the things that we should be thinking about relating to the vaccine. But I don't imagine I'll have the answers to everybody's questions, but I do want to hear any concerns and questions so we can have as much of a discussion as possible. So starting off, the goals of this talk, I'm going to try to discuss briefly the development process for the COVID-19 vaccines, give an overview of 3 of the vaccines that are closest to distribution in the US now, coming to here in Oregon in the next week, potentially. Discuss the phased vaccination program that OHA has developed and what that will look like when different people will be getting the vaccination. Review what to expect with the vaccination in terms of side effects and what to do afterwards. And then address some of the common safety concerns related specifically to COVID-19 vaccines. And in all of this, I think there's two things I want to kind of be able to address for everyone is that, how can you as individuals feel comfortable, knowing what you need to know in order to just make an informed decision about when and whether to get the vaccination. And then also how you can comfortably address concerns that your patients might have, so we can have constructive conversations with them, because we want to be able to talk with our patients productively about it. But the first step is to be knowledgeable and comfortable ourselves about the vaccine, so we can make those decisions for ourselves as well. So first, a brief overview. I really like this slide. This came out from a paper in Nature, the Nature magazine, back in September. But I still think one of the best ways to describe the vaccination development process. At the top, this is traditional vaccine development. With the timeline of several years for design and preclinical studies, 2 to 4 years for process development and toxicology studies. And then you submit the IND, you start phase 1 trials for 1 to 2 years, then phase 2, then phase 3. Then you submit your BLA to the FDA, you get reviewed, and then after 1 to 2 years of that, you can start producing and distributing your vaccine. So generally, this is a 15 to 20 plus year process for developing and distributing a vaccine, which of course, most people are familiar with by now, that it takes so long. And so the natural question a lot of people have is, how has this vaccine or these vaccines for COVID been made so quickly? And there's a few key things. One is we already were able to cut out a lot of the early preclinical design and development process, because we had a strong foundation of knowledge to start with. We had pre-existing data from SARS and MERS vaccine development that we were able to translate directly into the COVID vaccines that were being made. So that gave us a big head start. And then probably the biggest factor is there was just a whole bunch of money thrown at this. There's a lot of political will and a lot of public pressure and a lot of funding that incentivized really rapid production. So that allowed the production companies, the biotech companies, like to begin really rapid phase 1, 2, and 3 trials and production in overlapping and staggered processes, without having to wait for different approvals, and knowing that they would get funding going forward. They were able to basically do all of these things at risk. So they were able to start overlapping phase 1 and 2 trials. They were able to start phase 3 trials very quickly, because everything was at the top of the list for approval. They started production of vaccines before phase 3 trials were even completed, knowing that it was at risk, meaning that if for some reason the vaccine doesn't get approved, they're not going to be reimbursed for this. Some of the companies are, because of the Warp Speed funding, being reimbursed anyway. But so they don't have to worry about this cost benefit analysis. And then the other last component is that we are doing what's called the emergency use authorization, which is what was already mentioned is happening today. FDA is reviewing the Pfizer vaccine today for the EUA. And then on the 17th, it'll be reviewing the Moderna vaccine for the same thing. So that is allowing us to get the vaccines to patients more quickly than normal. And we'll talk about more what that means in a little bit. So comparing what this means, more specifically, how this development is different and the same compared to prior vaccines. So similarities, there have been no stages of development that were skipped. Everything has been done the exact same it would have been in terms of which steps needed to happen. They've just been done more quickly, but there haven't been any corners cut, as you can see in that infographic. The trials, the phase 3 clinical trials, they're the same that you would get otherwise, 30,000 to 40,000 participants, the same you had for HPV, rotavirus, other vaccines that have been made. You have the same duration and standards of safety data that are required for other vaccines. A lot of concern has been brought up to the short time frame in which the studies have been implemented. There's really the safety profile that vaccines require is typically 2 months. There's some argument that maybe we need 4 months of safety data to really have robust safety data, but generally pretty much all vaccine side effects in the history of vaccines, they happen within 2 months of vaccination. So that's the standard for determining safety. What's different about these trials is that they're much faster because of the things I mentioned already, the pre-existing vaccine development, greater funding available, rapid enrollment in trials made a big difference. I'm involved in a couple of studies, or at least one other study right now, and trying to enroll patients is a big pain. For anyone who's done a study or been involved in a study, it can be very challenging to enroll patients in studies. But in this case, everybody wanted to enroll very quickly, so there was a lot of rapid enrollment, which made it very easy to quickly start the trials. And then there was a lot of cases. The pandemic is horribly uncontrolled, which for clinical trials is great because it means there were a lot of sick people in those trials very quickly. So it allowed us to quickly reach the level of power we needed in those studies to have good safety data and efficacy data. The main difference with the other difference is that we have this emergency use authorization, EUA, that is being sought before licensing. And that's because typically for licensing, you need a longer duration of efficacy data. That's the data that shows that the vaccine works. We know that it works so far. We don't know yet how long that you get immunity from those from the COVID-19 virus after vaccination, because we haven't tested it for more than a few months now. So that data will only come with more time. And once it does, then we can properly license the vaccines. But for now, we still have the data that shows that they're safe, that we would otherwise have, that's allowing us to safely use them without necessarily knowing how long the protection they give us will last. I'm going to talk specifically about the three major vaccines that are in the forefront of coming to being available for us in Oregon. Pfizer, the one that's being heard today by the FDA, it's an mRNA vaccine. So I'll briefly go over mRNA vaccines shortly, but basically the phase 3 trials had 43,000 participants. There were no serious side effects in the vaccine. It demonstrated significant efficacy, 95%. And the way they measure that was based on comparing vaccine recipients to saline shot recipients, and the difference in prevention of symptomatic disease. Moderna, same thing, an mRNA vaccine. Main difference with Moderna is it doesn't require that same ultra cold storage that Pfizer requires. They had 30,000 participants in their trials. Similar outcomes, 94.1% of efficacy in preventing symptomatic disease compared to, with vaccination compared to a saline vaccine placebo or saline shot placebo. mRNA vaccines, some of you may have some level of knowledge about these already. I got this analogy from a colleague of mine, and I love it, that mRNA vaccines are basically like fortune cookies. So the cookie here is the liposome, just the fat molecule that is storing the vaccine, storing the mRNA. That is brought to your table at the restaurant, which is what you do when you inject the vaccine into your muscle cells. And then your cells unwrap, they eat that vaccine, they take it into the cytosol, then they disassemble that cookie layer, the ribosome, and then out of the middle comes the mRNA. The mRNA here in the fortune cookie analogy is your fortune here. It has instructions, it has information that tells you something. You're able to interpret that information and use it to make decisions. And in the case of the vaccine, the mRNA codes for the spike protein on the COVID-19 virus. And then you throw that fortune away. You don't eat it, you don't absorb it into your DNA or anything like that. It gets disassembled rapidly. The spike protein is able to go to the surface of the cells like it normally would with any other protein your cells make, but then the body recognizes it as a foreign antigen and creates antibodies leading to your immune response. That's a very rapid overview of mRNA vaccines. The third vaccine that's coming up is not mRNA. This is the AstraZeneca vaccine. It's a little slower behind, which is because it's not an mRNA vaccine. One of the main advantages of mRNA vaccines is that you just need a computer to know the code, and then you assemble an mRNA strand. You don't need to use any kind of virus or vectors. The AstraZeneca vaccine is what's called a non-replicating viral vector vaccine. It works a little differently. It uses a simian adenovirus. It's a strain of cold virus that doesn't infect humans, that we don't have any immunity to, and doesn't replicate. The virus that they're using, they've modified the genome so it can't replicate at all. and it's included a vector from the COVID-19 vaccine to show that same spike protein. So it works by you get this non-replicating virus and you generate antibodies to that spike protein in the same way you would with the normal disease. Those phase 3 trials are still underway. They use a meningitis vaccine placebo rather than a saline placebo. Preliminary results show maybe 70% of efficacy, possibly up to 90%. They're using an outcome of weekly nasal swabs rather than symptoms is the main difference there. The phased vaccination program for Oregon, this graph is a little out of date, but the graph lines themselves are still useful. Initially, starting potentially December 15th next week, we're going to start having a limited supply of vaccines, and the phase 1A groups of people will start to be able to be vaccinated. It will probably have to be a tiered approach because there won't be enough supply for everyone. Eventually, when we get to a larger number of doses available, we'll be able to expand beyond those initial populations, the initial populations being healthcare workers and long-term care facility residents and staff. And then after that, we'll eventually get to a point where we have sufficient supply and we'll be able to gradually expand to the majority of the population getting vaccinated or being able to be vaccinated. This is the ACIP's recommended phase 1 sequence, ACIP Advisory Committee on Immunization Practices. So this is the order in which we plan to vaccinate, or the populations that we plan to be able to vaccinate in order. 1A, again, HCP, healthcare professionals, LTCF, long-term care facility residents, followed by other essential workers, and then other high-risk adults. Briefly, what to expect when you get the vaccine. They'll require 2 full doses, most likely, Moderna and Pfizer, 3 and 4 week apart doses. And the side effects that have been noted so far mostly have been either no side effects or mild fever, body aches, or headaches, particularly after the second dose. In a smaller proportion of people, you can have pretty significant headaches, myalgias, fevers. And there's some people who had pretty extensive discomfort for that duration of usually maybe 12 hours where you have significant side effects. Those are the main things that we've noted so far in the trials. In terms of what to do after vaccination, this is going to be important to remember for ourselves and for our patients. The vaccine is not a license to go out and resume partying everywhere and do everything pre-COVID times. We are still going to be in the middle of a pandemic for over a year, and probably well more than that. It will take quite a while to get to the level of vaccination that we need in order to have herd immunity, in order to control the pandemic. Best estimate is at least a year to a year and a half. And that's precluding any unforeseen barriers and bottlenecks in dissemination and distribution. And of course, depending on the level of hesitancy that we see in the community, as well as ongoing issues surrounding licensing and data and all of that. So that said, it means that even after vaccination, we need to continue to take the same control measures that we've been encouraging people to take so far. That's going to remain the most important thing. Social distancing, minimizing large gatherings and crowds, wearing masks when in public or indoors, hand washing frequently, avoid touching your face, all of that. Now I'm going to briefly address safety concerns that have been brought up. I think the important thing to remember here is, first, I'll go over these pretty rapidly, and so if there's any things that people have more questions about, I can talk about those at more length afterwards. It's important to remember, if you're thinking about talking to patients about vaccines, I wouldn't proactively bring up all of these concerns that I'm about to list, because there's just always going to be more and more things that people can worry about. It's more important to ask first what their concerns are and speak to those concerns. And this is true of all vaccine education. What's really crucial is that you first listen to your patient's concerns, ask where they're coming from, what their thoughts are, what they know and don't know, and what they would like to know. Ask permission to share information for them, with them. Empathize with the concerns they have. Those things need to be the focus: the empathy, the asking permission, and the listening. The providing of information is really the last and least important step in many ways when it comes to talking to patients about either the COVID vaccine or any other vaccine. Patients really need to feel listened to, and they need to have their specific concerns addressed, and they need to think and know that you care about their safety. That is the only way that we're going to have any successful conversations about vaccine hesitancy. So bear that in mind as I go through these things. How are we monitoring safety regarding the COVID vaccines? They have the same pre-market safety data as all other vaccines. As I had mentioned before, 2 months is the standard, and that's what we have already. They're going to have 2 years of ongoing follow-up in the phase 3 clinical trials. We're going to have the same post-market safety monitoring using the VAERS system, Vaccine Adverse Event Reporting System, with which some of you may already be familiar with, where anyone can report any adverse effect, and it's just a huge data gathering system that allows us to see if there is any unexpected side effect happening at higher rates. So that will still be in place. It's one of the most extensive and in-depth safety monitoring tools that we have for any medication. In addition, there's a new vSafe monitoring program. It's a smartphone-based tool to monitor side effects. They're going to follow up with texts for 2 weeks post-vaccination. And then if anyone reports serious side effects, they'll get a call directly from a CDC safety team to discuss that follow-up and those effects. So a very, I think, potentially useful new safety tool that we're going to have in addition to what we've already had to be able to monitor and keep safe the vaccines that we've had for decades, which again are already the safest medicines that we have. Long-term side effects, this is obviously concern for lots of people because as I've said multiple times, most side effects you're going to see within 2 months, almost all side effects really. But how do we know if it's really safe in the long term? We can't really because we haven't studied it long term. And that's technically true. That said, there has never been a vaccine that has had long-term side effects or that has had side effects that have not consistently appeared in the first 2 months following vaccination. And usually it's much sooner than that. So there's no significant plausible reason to think that would be different here. There's no evidence to suggest that there will be long-term side effects. But of course, we do need to be forthcoming that, we don't have the safety data. There are some differences with an mRNA vaccine. We can't be 100% confident that there's not going to be anything new and significant that we learn in the coming months that we don't already know. And there likely will be things that we learn. It's just, I think, very unlikely that anything will have a significant impact on the decision to take the safety regarding the vaccine. The other thing to bear in mind is we don't have any more long-term safety data for the vaccines than we do for the infection itself. So, there's going to be concerns about how do we know this vaccine is safe long-term. You can ask the same question about the COVID-19 infection itself, and the answer is the same. We don't know. It's new, and it could be just as bad or worse. A good example here is measles. Measles vaccine has 0 long-term side effects. Measles infection under a year of age has SSPE or SPPE, subacute pansclerosing panencephalitis, I think. And for those who aren't aware, this is a chronic, long-term neurologic deadly complication of measles. If you get measles under a year, up to several years, even 10 years later, you can get SPPE, and it is universally fatal. That's something that we didn't know about measles until it started happening 10 years after measles infections, and it happens with the disease and not the vaccine. So there's no reason to think that taking a vaccine is a higher risk than getting an infection, either in the short or long term. There's a lot of reasons to think that it's actually much lower risk. This is kind of a whirlwind tour of a lot of the mRNA vaccine concerns that have come up specifically about mRNA. One, that it's new and unknown. Could the mRNA linger in cells? Could it integrate into DNA? Could it cause infertility, autoimmune disease? What about antibody-dependent enhancement? And all sorts of other very nuanced and specific and detailed concerns. And there's a lot of worryingly well-written blog posts about this with a lot of pseudoscientific hand-waving that sounds very smart and is very difficult to look at critically, especially when it comes from people with significant biochemistry knowledge talking about things like reverse transcriptase and DNA integrase and all of these pathways in mRNA cell biology. So it's it's going to be important that we try and look at this critically and explain it to patients who have those concerns in a way that they understand. With traditional vaccines, more older vaccines, we have the benefit of knowing that it doesn't matter what kind of theoretical problems that any anti-vax group comes up with. We can dismiss them saying that we have the safety data, so it doesn't matter what they're theorizing. We know it doesn't happen. That's not true with mRNA vaccines. All we have to combat these theories are, actually having to dive into the science to some extent. So it is a lot harder. Briefly, though, to kind of address some of these concerns, mRNA vaccines, they may be new, but they're not unknown. They have been tested in clinical trials since 2014 for influenza, Zika, rabies, and CMV. They're also used in multiple clinical trials for mRNA drugs that encode for antigens that help to fight different cancers. The mechanism of action is fairly straightforward. It's actually a little easier to understand in some ways than a typical vaccine, and there's no probable mechanism for long-term side effects. The mRNA in the vaccines is destroyed within hours. It gets into the cytosol, it gets read, transcribed, and then gets disintegrated, disassembled. It doesn't enter a nucleus. It doesn't have a way to enter the cell nucleus. It can't be transcribed into DNA with reverse transcriptase, something you might hear floating about in the internet. We don't express reverse transcriptase in our genes and even in our cells. And even if we did, it requires a specific binding site on mRNA, which this mRNA doesn't have. If it did, then the COVID-19 vaccine could also integrate into our DNA in the same way. And just because you get transcribed into DNA doesn't mean you can get integrated in our genome. If you see side effects caused by the spike protein or the mRNA encoding for it, including things like antibody-dependent enhancement, which for those who don't know is the idea that if you have antibodies against the disease and you get sick again, those antibodies could make the disease worse. If that were true, we would already have seen that with vaccine recipients in the trials who got sick with COVID. They would have gotten worse illnesses, but instead they got more minor illnesses. We would also see it with COVID-19 infections in the country itself. So people who got sick with COVID-19 and then got sick again would have antibody-dependent enhancement. So this is something that we should have seen already, and there's no reason to think it would be worse with a vaccine compared to natural infection. And then last thing to be mindful of is overall this idea that, maybe there's some altering of genomes or mRNA persisting. If our cells could just frivolously preserve and integrate into our genome whatever random mRNA strands were in our cytosol, we could cure every genetic disease, because that's what gene therapy is. We're trying to change our genome, and so far it hasn't worked. So we don't know how to do that. And if we did, we'd be very successful at curing pretty much almost all genetic diseases. But more than that, if our body did that, we would always be mutating our genome, because there's thousands of viruses that are injecting their mRNA into us all the time. And the fact that our bodies have evolved with that means that they know how to protect itself from those RNA strands. We're not going to be changing our genome as a result of that. So that's kind of a brief overview. Takeaways here, vaccines are being developed following the normal steps of vaccine development. There's no steps being skipped. It's just happening faster because we have political will, public pressure, and money. And those make a big difference. And it could be a good lesson for us all to learn going forward, that if we focus more on scientific advances, we could actually do a lot of good for people, even when there's not a pandemic. When a vaccine becomes available, it will be distributed using a phased approach. So healthcare workers, most of us, we're going to be first in line to receive it. Hopefully, with many of us getting it, that will be some reassurance for our patients, knowing that, we're not using them as test subjects. We're doing this in a scientific way to best control the pandemic, which means protecting the highest risk people first. We're still going to need ongoing pandemic precautions. We still have to be staying safe, keeping distance. The vaccine is not going to immediately take away this pandemic. Like any other vaccine, there are side effects, and those side effects so far seem to be limited to fever, body aches, and headaches. There's no serious side effects noted so far. No evidence to suggest or reason to believe that that will change over time. And lastly, these mRNA vaccines are new, but not unknown. These are some references of things that I was looking through that I found very helpful. Some of these are actual presentations and video lectures. So feel free to check these out. I think they're very useful. They have a lot more detailed information than I had the time to go through right here. And that's pretty much everything. So That was as fast as I could go. It's still 30 minutes, but if there is any time for questions, I'd be happy to take any and go into more detail on any questions that you guys may have.
That was actually awesome. Like, I've been listening to a lot of presentations lately, and they've just been like just tripping over the words, because it's like there's just so much information and so little time to be able to get it out. So thank you, Dr. Hassan. That was really great. The producer today that I didn't introduce in the beginning is Kelly Illich. She is with the Oregon Center for Nursing. She has been collecting a lot of your questions. So Kelly, can you just kind of go over some of the questions that have come in so far?
Absolutely. Thank you so much. And I have a couple that I've pulled out, and then I'll look at the questions that are coming in right now. But pardon me 1 second. So we had several people, including Sean Moore, Sharith Ravinius, and Lisa Snodderly, who are asking about whether or not these COVID vaccines are going to be recommended for people who have already had COVID, and if there's any answer about that yet, Dr. Hassan.
Really good question. There's no answer yet. So far, the studies have been limited to healthy participants, so we don't really know who. I mean, hopefully we'll know soon who it will be recommended for when we get the emergency use authorization. But in terms of the actual data, we don't yet have good data about one, how long you stay immune after you get the infection, and two, whether that means you should get a vaccine after being infected or how long after being infected. I think currently I did read from OHA that their initial thoughts are they're not going to vaccinate anyone within 90 days of them having been infected. We also don't really yet know about certain high-risk populations. Obviously, we do know about elderly populations that they can get it. They were explicitly studied, but people with certain autoimmune conditions or autoimmune medications, people who are pregnant or people with young children, those populations haven't been well studied yet. So we don't have great data on that yet. So it'll take time before we really are able to say, okay, this is how safe it is and recommend it is in those populations. But that'll happen in a phased approach now that we've had good safety data on the more general population.
So Jessica Quinlan had also asked, are they anticipating that this is a shot that you'll need to get yearly, like your flu shot?
There's not really good data on that yet either, again, because the main piece of data we're lacking right now is that efficacy data. We know the vaccine works. Those vaccines so far work 90+% or so, but we don't know for how long. So that's what the phase 3 trials are going to learn in these 2-year follow-ups. How long does immunity last? And what does that mean about repeat immunization?
And then Julianne Luttrell had asked if you have any idea about what the recommendation will be for use, for vaccine use with children, or maybe I'll tag on, what is the age floor for using these vaccines?
Yeah. Generally, initial studies are done on populations 18 and up. The Pfizer vaccine had included patients down to age 12. They don't have a lot of patients in that population, but they did enroll some. I don't remember the exact number. And I think Moderna is going next to move down to those lower age populations. So far, again, there's not really any great data on the use in kids, but they're going to be doing it gradually, usually 12 to 17, and then I think 8 to 12 or so, and younger going from there. It's, I think in a way that's some good news, or it's something we can use to reassure parents, is that we don't have to use this for our kids first. We can test it on ourselves so that we don't have to expose our children. We can use the vaccine on ourselves to protect our kids. And again, I mean, if we're able to vaccinate a significant amount of the adult population, that may be the most that is required. I think it's likely at some point we will want to vaccinate children as well. But if we can get the adult population vaccinated, that will go a long way towards curbing the pandemic and, of course, protecting those at the highest risk.
Thank you so much. So we also had a couple of individuals, Lois Hine and Aaron Ely, who were talking about the some of the early reactions or the recent news about some of the more severe reactions to the vaccine. Aaron specifically had said the Wall Street Journal today had stated that 2 people had anaphylaxis with the Pfizer BioNTech vaccine in UK.
Yep.
She was wondering if those 2 patients had had prior severe allergic reactions to other things. And her specific question was, what sort of questions or pre-screening will we need to do with our patients about allergic reactions? Or are there populations that are more at risk for anaphylaxis versus low risk populations?
Yeah, it's a good question. I think I heard before we started that some people were on the, there was an FDA call yesterday morning, and they addressed that same issue, this concern about the headlines from the UK of they're recommending against it and people with history of severe allergies. The bottom line, and it was interesting hearing the FDA's response. He was a bit perturbed by it because it was very much, it was just a lot of headline seeking reactionary stuff. And his emphasis was that, we really need to look at the data. We need to slow down and look at the data. You have one case when we start vaccinating of a severe allergic reaction. That's important to look at, but that doesn't mean we need to forget the 30,000 or 40,000 for Pfizer cases of patients who we had clinical studies of for months. We need to know what happened in that specific case. We need to investigate. So far, I don't know that information, and I think it's still being looked into. I think it's very unlikely that we're going to have a change in our recommendations based on 2 cases out of everyone who's been vaccinated so far. But in order to determine that, they'll have to look at what happened in those cases. So those questions that were asked, was there a history in those patients, or was there some other component that explains why they had that reaction? Again, I have no idea right now. I don't know why they had those reactions, and I don't know what the implications will be for the recommendations. I think a lot of this is going to hopefully be answered in the coming weeks. Once we get emergency use authorization, that presumably will come with, the guidelines for who should be getting it and what the restrictions should be, what kind of questions we would need to ask. I would anticipate the questions will be somewhat similar to what we see for flu, things like, have you had severe allergic reactions in the past? Have you had other autoimmune diseases or things like that? How much that will determine whether we, change our, who we give vaccines to, I don't know. So far, there doesn't seem to be a reason to exclude people with any significant prior history. But again, there's not necessarily that great safety data to show that we should include them either.
So Christy Klosterman had asked if you're anticipating, or if there's anticipation that the side effects for the viral vector vaccine will be similar to the mRNA vaccine.
Well, again, I'm no expert, and so I can just speculate here. And my speculation is that, I think it probably will be similar, because in general, vaccines all create pretty similar side effects. There are specific side effects, differences between different vaccines, but most vaccines can create things like fever, headache, fatigue, myalgia. And it's in particular, since these vaccines are essentially generating what's probably a very similar immune response. Your body is recognizing the spike protein, creating an immune response to that. It should be pretty similar. There are some differences in that the non-replicating viral vector vaccine, I think, does have a more broad immune response from different parts of the immune system, the type A and B response. I may be mixing up the nomenclature there, so that may change things a little, but I suspect it will be the same. But again, it's just speculation. We'll have to really see. So far in the preliminary data, the side effects are pretty similar, but that is just preliminary from, I think, 11,000 or so participants. So we'll have to wait for the final data to know for sure.
And then Jennifer Bransfield asked if patients who have side effects after the first dose are unwilling to have the second dose, what does that do to the effectiveness? And then I think I would just riff off that and saying, what do we need to do to encourage people to work through those first side effects and go back and get that second?
Yeah, really, really good question. So I don't know the specific data on how immune you are after one dose. I don't know that they've actually specifically studied that beyond the fact that they found with a single dose you don't get enough immunity, which is why there are 2 doses. So, you know, I don't think I could provide a better answer than that to that question, except that likely, you know, you're not going to have very good protection. You'll probably have maybe some short-term protection. In order to try and, to your second question, to try and promote that second dose for people even when they do have side effects, I think it's important to be very straightforward about the fact that, you know, there are possibly side effects and prepare them for that. In particular, prepare them for the possibility of the more severe side effects. That it's very uncommon and very unlikely, but there are going to be some people who are going to have, you know, those, you know, that half a day where you just feel really, really bad and you have a horrible headache and you're bed down and you have muscle aches. And there's a really good case report from someone who was in one of the trials, I think in the UK, who talked about his experience getting it and how horribly he felt. I think it's important not to necessarily emphasize that, but to explain that that is a possibility. You might have these really bad side effects. Most people will have minor side effects, but if people are prepared ahead of time and say, okay, this could happen, this is what I might expect, then it'll be less of a negative response for them if they do have those side effects. And the other way that I think will be helpful to explain it is if you have those side effects, that's a way to know that the vaccine is working. It's eliciting an immune response. So your body is creating an immune response, maybe not in all the ways that you want, but at least you know you're getting immune. So that's some reassurance to provide in that sense.
If I can follow up, I was actually sitting in on an OHA webinar yesterday where they said that the FDA released 100 pages of Pfizer data from the phase 3 clinical trials. And they said it was about 52% effective after the first dose and 95% effective after the second dose. But that 52% is just not enough. So that's why they strongly recommend, and that's why it's a 2-dose.
Thank you. That's great. That's really good to know.
Yeah.
So Carrie Goldstein has asked, would you encourage someone who has had severe responses, but not necessarily an allergic reaction, but a severe response to the annual flu shot to get the COVID vaccine? Or is that maybe an indication that this is not going to go well for them?
I think it's a little bit of a hard question to answer. On the one hand, it is true that there are people who are going to be more reactive in general, you know, maybe who are more atopic and are more susceptible to, you know, autoimmune problems and things like that. But that only goes so far. And there's, you know, because you're allergic to one thing does not mean you're allergic to other. And for example, having an allergy to one type of food does not necessarily in any way mean you're going to be allergic to another type of food.
Mm-hmm.
Now that's not always true. I mean, there are some food allergies that go hand in hand, and I'm not an allergist and I can't recite them off the top of my head, but it is true in some cases. But in particular for flu, you know, there's not really any reason to think that the flu vaccine would share immunoreactivity, reactogenicity with the COVID vaccine. They're very, very different. They're made entirely different ways. Flu is you know, either live attenuated if it's nasal, or the killed virus if it's intramuscular. But the Pfizer and Moderna vaccines are mRNA vaccines. It should be significantly less immunogenic. It's a very simple vaccine. You have no preservative, no additive, no adjuvants. It's just a liposome with a strand of mRNA inside. The liposome gets eaten by the cell. It's unwrapped in the cytosol. The mRNA expresses spike protein, and then all you really should experience is your body creating an immune reaction to a single spike protein, as opposed to the 29 proteins you would normally get an immune reaction to if you were infected by COVID-19. So it should be very, very different from any kind of side effect from flu. So, but again, I don't know that I don't expect they're going to make any specific recommendation like that, but I don't know that yet. We'll have to see what they say when they've reviewed all the data.
So another question from Erin Ely, and she asked, is the vaccine used to reduce the symptoms of COVID, like to make the COVID symptoms less severe, or does it, I'm sorry, I lost my place on the page. Does it reduce the spread of COVID, or both?
That's a really good question. So the short answer, we don't know yet. I can get into the science a little bit on this with the type of vaccine that we have. We get an immunoglobulin G response immunity. That's the type of immunoglobulin antibody that we make that makes us immune, which typically creates lower respiratory tract immunity. The upper respiratory tract immunity is more mediated by secretory immunoglobulin A, which is what is expressed on your mucosa in your gut and your nose and other mucosal surfaces. That would be something that you might get more of through a nasal and inhaled vaccine. So because of that, I think that it's likely that we may not see great reduction of necessarily of complete immunity to COVID, but rather more asymptomatic infection with COVID. But again, that's entirely speculation just based on this physiology that I've explained. We don't really know yet. We're going to have to see, does it make people immune, or does it just keep you from getting keep you from getting sick? Could you still be an asymptomatic carrier? So far, we don't have that answer, and that will, make a big difference in terms of how many people need to get vaccinated to really stop the spread.
If I can get you, can I ask a quick question? I noticed one of the things that you said was you had like this 4-step process when you're trying to talk to people that are concerned about the vaccines. Would you mind expanding on that just a little bit more about the listening and asking what they already know and the empathizing? And I mean, this whole group, we love all this information that you're giving us, but to translate that for other people that don't necessarily have the anatomy and physiology background that this group has. Can you talk about that a little more?
So the premise is really, it's about motivational interviewing. When you talk to patients about the vaccine, your goal should not be to convince them to vaccinate, because if that's your goal, you're more likely to fail. Your goal should be to understand where they're coming from, make sure that they feel heard and listened to, and then help them come to a place of understanding and kind of address their concerns. Developing that trusting relationship and having an explanation, similar to what you described when you met with your pediatrician, just having a conversation where they can kind of go over your concerns. That's really what makes the biggest difference. So I always start, when I talk with families about any vaccine, and if they're not sure, before I even know they're unsure, I say, this is what you're due for. What questions or concerns do you have about these vaccines? And then, a lot of times you're going to get, there's a very wide range. Some people are going to be completely adamant they don't want any vaccine, and others might say, I'm not really sure, I'm a little uncertain. I think the first thing to do when you approach someone who's more hesitant is, again, ask for more information. Ask them to tell you a little bit more. And some people might just kind of shut you down and be more dismissive and say, oh, it's not really, I don't believe in it. It's against my religion. It's against my culture. We don't do that in our family. These kind of meaningless answers that are just not really how they really feel. It's just a way to not have the conversation. And I would encourage people to press a little more and say, well, can you tell me more about that? I want to learn more, and really make sure they know that you're interested. And help and try to listen to what their actual concerns are. And then it's tempting when you do that to immediately jump in and correct and say, oh, well, you think that this is going to cause autism. Well, we have all these studies showing it doesn't cause autism. And that's not helpful. That's not what they need to hear. The first thing to do is empathize and say, look, I understand your concerns. In the case of COVID, say, I get it. It's new. There's a lot of unknowns about it. And, we're still learning, and it's scary to figure out how to navigate in this scary time with a pandemic. So acknowledge that they're trying to make the best decision for themselves, and that you understand that, and that you want to help them do that, not to force them to make a decision they don't want to make. And then I always proceed by asking for permission. Ask them if it's okay if you share with some more information, or if you talk more about it. And that serves two purposes. One is you can immediately not waste your time with the 1% of people, hopefully it's only 1% with COVID, who are just not going to have a conversation. Your time is valuable, and you shouldn't be wasting it talking, just nonstop with people who are not going to change their mind. And some people aren't. And those people, when you say, can I have, do you mind if I tell you a little more? Do you want to talk more about that? they're going to say no. They say, I don't want to do that. And then just respect that and say, you know what? Okay, that's fine. We don't have to. And then the second thing it does is for the rest of the people who say, yes, actually, that's fine, you're getting their permission before you inundate them with information. And that means they are allowing you to present this to them, and which means they're going to be more receptive to it. They've told you, yeah, you can tell me this. So then they will be more likely to actually hear what you're saying. They're not going to feel lectured to as much. That's what I do first. And then I address their concerns. And if I don't have all the answers, which again, I frequently don't, it's okay to say that and just say, well, I'm not really sure about that, but I can tell you these are reasons why I'm comfortable making the decision for myself.
Yeah, thank you. I think especially with this one, since there are so many unknowns, I think it's absolutely valid that there are going to be people. I mean, I'm one of them that I'm like, I'm a little nervous about this. This is a little scary, but but for me personally, I'm willing to do it because I would like to not live under a pandemic anymore. And yet other people, they might have other concerns. So thank you for sharing that.
And I should say that, along those lines, this is a key difference between the COVID vaccine and other vaccines is, I do say with, basically as close to 100% confidence as I can be in a scientific conversation that I recommend, routine childhood vaccinations for every child, barring a medical contraindication. I can't say the same thing for COVID-19. I do think it's a good idea. I do encourage everyone to vaccinate, but I can't tell you to definitively this is, the definite best solution. I think it is based on all the information I've shared with you all. But we all still need to be straightforward about, we don't have all the answers. This is what we know and this is what we don't know. I think we know a lot, and I think what we don't know is not as much as it's going to be made out to be. But we still have to be forthcoming about that, because patients are not going to be happy to hear us say, oh yeah, this is totally safe, it's totally fine, and you don't have to worry about it at all. There are valid concerns and we need to acknowledge them.
Yeah, great, thank you. So we're almost at the top of the hour. I think that Kelly, are there a few questions that we weren't able to get to?
There was really only one, and it was if there are any known issues or reactions with current common medications that people are taking. Like if you're on blood pressure medication, you should not have this vaccine, or if you're on an immunosuppressant, you should not have this vaccine.
Yeah, so as far as I know, no. And I think the only medicines that will potentially pose a problem in terms of, I don't think there's any medicine that we really need to worry about that will actually have a reasonable chance of causing a contraindication of the vaccine. But I think the medicines that we may need to worry about and before we get, wait for safety data before we proceed with, will be medicines like immunosuppressants. If people aren't immunosuppressants, then that's always the case where you may need a little more safety data specifically in that population before proceeding. And that we don't have yet. But again, I don't anticipate there will be any changes once we have that data. And I don't know, they may recommend initially to take it regardless of those medications. I don't know that yet.
So one last question that is another really interesting one, and this is from Christina Pinzon, and she said, this is kind of going back to this, we're rolling out this vaccine and we're still kind of mid-process. So how do you frame or leave an opening for providing patients with new information when it becomes available? Or is that something where you just wait for them to reach out? Or as providers, do you need to reach out and say, oh, there's some more information for this vaccine that I just gave you, here it is?
Yeah, that's a good question. And I think it's going to be a hard issue to address. I mean, the bottom line is we just are really bad at educating the public. I mean, I think globally, particularly now in this country, we just are not good at it. And especially in public health and in medicine, we don't do a good job of translating the science for our patients. And I think in the clinic setting is the one time where we really excel, because we can have those one-on-one conversations with people we have close relationships with. And that is the best time to try and encourage them and say, hey, look, let's talk about the COVID-19 vaccine. This is something that's going to be coming up shortly. This is what we know about it. but I think there's definitely room for improvement there. And one of the things I'd like to see more of, and this is, I think, going to be a lot just on individual practices and providers, is to just have more open conversations within the community. So, Boost Oregon has a blog that we're going to be trying, we already have, but we're trying to update with more COVID vaccine information. So, that will potentially be one source to refer people to. We're my own clinic, Oregon Pediatrics, we have our own social media and our own blog site where we're going to try to keep up-to-date information that we'll refer patients to. I think finding ways to connect patients with the clinic so that, and some clinics may already have this kind of thing set up. If you have, an email list serve or something where you have weekly newsletters or things like that. I think it's important to find ways to engage with patients so we can have meaningful updates with information in a way that they're receptive to. But that's challenging because not everyone's going to go and read your blog. Not everyone's going to want another email to be subscribed to or to follow you on social media. So it's going to take some ingenuity and some new thinking and definitely just connection with and building community within the practice, I think.
Great. Thank you. All right, we are at time. A lot of you had to jump off already, and Dr. Hassan, thank you so much for coming and sharing all this information with us. I think this has been extremely helpful, and especially for this group. I'd love to hear from you guys how you felt like this went. Obviously, there's a lot more that we need to know, so it's possible we're going to be doing this again. So Erin, thanks for the clap emoji. That's perfect. I get Barbara Gaines is giving me the analog thumbs up, so thanks for that. Let us know if you want to have some more conversations about this. I think the more we learn about the vaccine, I especially think that the nursing community, particularly in Oregon, I think we can really do a lot to help alleviate some of the challenges around communication, particularly for the COVID vaccine, and just make the rest of Oregon as healthy as we possibly can. And with that, enjoy the rest of your Thursday, and we'll talk to you all soon. Thanks very much.
Thanks, everyone. It was nice to talk with you all.
Yeah, thank you.